ECG is the graphic representation of electrical activity generated by the heart. Usually it is dictated by the electrical activity generated from the SA node. The signals are detected by means of metal electrodes attached to the extremities and chest wall, and these signals are amplified and recorded by the electrocardiograph. Usually, ECG is recorded on a graph paper which is divided into 1 mm grid-like boxes. The smallest horizontal division corresponds to a 0.04 millisecond, and the bigger horizontal division with a heavier line corresponds to 0.20 millisecond. The vertical division measures the amplitude of a specific wave or deflection, and it is measured in millivolts. As you can see, this is the graphic representation of your ECG paper. ECG leads is divided into extremity leads and chest leads. The extremity leads is composed of 3 bipolar leads and 3 unipolar leads, while the chest leads is composed of 6 unipolar leads. The extremity leads records potential transmitted onto frontal plane. The bipolar leads measures difference in potentials between electrodes in two extremities. Lead 1 for left arm and right arm voltages. Lead 2 for left leg and right arm voltages. Lead 3 for left leg and left arm voltages. The unipolar leads measures the voltage at one locus relative to an electrode that has approximately zero potential. AVR for right arm, AVL for left arm, AVF for left leg, and right leg serves as an electrical ground. Chest lead is also known as a precordial leads. This is a unipolar recording obtained by electrodes in the horizontal plane. These are the graphic representation of your ECG, in which the P wave represents atrial depolarization, QRS complex represents ventricular depolarization, the ST-TU complex represents ventricular repolarization, the J point is the junction between the end of the QRS complex and the beginning of the ST segment. The atrial repolarization, which is low in amplitude, is usually not detected and is obscured by the QRS complex. There are 4 sets of ECG interval. The RR interval, in which the heart rate can be computed. The PR interval, the time between the atrial depolarization and ventricular depolarization. It is a physiologic delay imposed by stimulation of the cells in the AV junction area. The QRS, which reflects the duration of ventricular depolarization. The QT, or corrected QT, subtends both ventricular depolarization and repolarization. For ECG interpretation, you have to take note of the rate, axis, rhythm. Is there any chamber hypertrophy? And is there any infarction or ischemia? For the determination of cardiac rate or heart rate, you have to take note if you have a regular rhythm or irregular rhythm. If you have a regular rhythm, the formula is 300 divided by the number of big squares between the 2R wave, or 1500 divided by the number of small squares between 2R wave. If you have an irregular rhythm, the formula is you have to multiply the number of cycles in 6-second strip by 10. Normally, your ECG strip has an indicator at the bottom that corresponds to a 6-second marker. Normal axis means your vector is between negative 30 degrees to positive 100. So that is normal. Left axis deviation means your axis is more negative than negative 30 degrees. This can be a normal variant, but it is more commonly associated with left ventricular hypertrophy, left anterior hemiblock, or inferior myocardial infarction. You have a right axis deviation if your axis is more than positive 100 degrees. It is usually a normal variant, particularly in children and young adults. It can also be seen in a spurious finding due to reversal of the left and right arm electrodes. But it is usually associated in a condition such as right ventricular overload, infarction of the lateral wall of the left ventricle, dextrocardia, left pneumothorax, and left posterior fascicular block. You can determine the axis by using these two methods, the quadrant method and the hexaxial method. Normal sinus rhythm is characterized by a normal-looking P wave with a rate of 60 to 100 beats per minute. The cycle length do not vary by 10%, and the PR interval should be between 0.12 to 0.20 milliseconds. Your P wave should be upright in lead 1, lead 2, AVF, and left precordial leads, and should be followed always by your QRS. Sinus arrhythmia is a normal variant. The variation in the distance between the two R waves is related to the phases of respiration. Increasing rate with inspiration and decreasing rate with expiration. Sinus tachycardia is characterized by a sinus rhythm with normal-looking P wave followed by QRS with a heart rate of more than 100 beats per minute. Sinus bradycardia is characterized by sinus rhythm, a normal-looking P wave followed by a normal-looking QRS, but the heart rate is less than 60 beats per minute. Arrhythmias can be characterized as escape and premature beats, irregular rhythms, rapid ectopic rhythms, and heart blocks. Cardiac arrhythmias is usually caused by disturbances in automaticity, or what we call impulse initiation, disturbances in conduction, or combination of altered automaticity and conduction. Premature atrial beat, it originates suddenly in an atrial ectopic focus, introduces an abnormal P wave earlier than expected. Atrial escape beat is an atrial ectopic focus which is induced by a pause in the SA node. The stimulus is then conducted through the AV node to the ventricle. Premature ventricular complex is characterized by a not normal-looking QRS, an irregular rhythm, and the P wave is usually obscured by the QRS ST segment or T wave. Ventricular escape beats originates in a ventricular ectopic focus after a slightly longer pause in a pacing activity. AV junctional escape beat originate in a focus within the AV junction and stimulate the ventricle via the ventricular conduction system, yielding a normal QRS complex. Atrial fibrillation is characterized by a very rapid rate, an irregular ventricular rhythm with no discernible P wave. Atrial flutter has an average rate of 300 beats per minute. The atrial rhythm is regular. The ventricular rhythm may be regular if a constant degree of block is present, irregularly if variable block is present. P wave is usually characterized as a sawtooth or picket fence and are best seen in lead 2, 3, or AVF. Supraventricular tachycardia has a rate range of 140 to 280 beats per minute. It is regular in nature, the P wave may not be discernible, and the QRS complex is usually narrow. Idioventricular rhythm is characterized by a rate of less than 40. Impulse is ventricular in origin. There is absence of P waves. The QRS is usually wide, more than 10 milliseconds, and the T wave is opposite in the direction of the QRS. Accelerated idioventricular rhythm is an idioventricular rhythm with a rate of 40 to 120 per minute. Ventricular tachycardia is defined as 3 or more PVDs in a row. Can be characterized as sustained or non-sustained. Torsade is a form of polymorphic VT in which the tracing appears to be twisted into a helix. This form of ventricular tachycardia degenerates relatively often into a ventricular fibrillation. Ventricular fibrillation is a very dangerous rhythm because it has no effective organized ventricular depolarization. Heart blocks can be a sinus block, an AV block, bundle branch block, or a hemi block. Sinus block is when your SA node temporarily fails to pace for at least one cycle. So there will be no P wave with that missed cycle. First degree AB block is characterized by a normal looking P wave followed by a normal looking QRS, but the PR interval is prolonged, more than 0.20 millisecond. Second degree AB block has two types, Mobic type 1, which is also known as Wenckebach, and Mobic's type 2. The Mobic's type 1 is characterized by a progressive increase in PR interval until one P wave is blocked. In Mobic's type 2, the PR interval does not lengthen before a drop B. In third degree AB block, the rhythm of the atrial and ventricular are usually regular, but dissociated. The QRS is normal looking when block occurs at the AV node or bundle of His, widened if block is at the level of bundle branch. The PR interval varies because the atria and ventricles are depolarized independent from each other. Bundle branch block is a prolongation of the QRS interval. It is said to be complete if the QRS interval is greater than 120 milliseconds and incomplete if the QRS interval is less than 120 milliseconds. The QRS vector is oriented in the direction of myocardial region where the depolarization is delayed. T wave is typically opposite in the polarity to the last deflection of the QRS. Right bundle branch block is characterized by a QRS vector oriented anteriorly and to the right. The ECG pattern of RSR in V1 and QRS in V6 is common in subjects without structural heart disease, but these can also be seen in patients with congenital ASD and acquired valvular or ischemic heart disease. This is an ECG example of a complete right bundle branch block. Left bundle branch block is characterized by a predominantly negative QS complex in V1 and entirely positive R complexes in V6. It is often a marker of one of the four underlying conditions, such as your ischemic heart disease, long-standing hypertension, severe aortic valve disease, and cardiomyopathy. This is an ECG example of your complete left bundle branch block. Anterior fascicular block is characterized by an RS ratio of less than 1 in 2-3 AVF. Posterior fascicular block is usually nonspecific and characterized by R waves in leads 1 and AVL and a Q wave in lead 2, 3, and AVF. A classic pattern and evolution of infarction. An abnormal T wave, which is prolonged, increase in magnitude, either upright or inverted, and then an ST elevation in leads facing the injury with reciprocal depression in the remote opposite leads. A Q wave may be present, And then the QRS complex may diminish and may be replaced by QS pattern. This is how you localize the infarction using the ECG leads. This is an example of your ECG with anterior wall MI. This is an example of your ECG with lateral wall MI. This is an ECG example of inferior wall MI. Right atrial enlargement is characterized by an atrial vector that is increased in amplitude greater than 1.5 mm and shifted to the right. The P wave is peak or pointed in 2-3 AVF, and this characteristic is usually seen in patients with COPD, and it is also called P pulmonale. Left atrial enlargement is manifested by prolongation of the P wave, shortening or absence of the PR segment, and shape of the P vector to the left and posteriorly. P wave duration is 0.12 millisecond or longer, and it is also known as P mitrale. Right ventricular hypertrophy is characterized by a right axis deviation, an RS ratio greater than 1 in lead V1, and an ST depression in right precordial lead, or what we call a strain pattern. Left ventricular hypertrophy is characterized by an increase in the voltage and shape of main QRS axis posteriorly, superiorly, and to the left. Prolongation of depolarization, gradual shift of the ST segment and T wave in the direction opposite to the QRS complex. Presence of LA enlargement increases the likelihood of underlying left ventricular hypertrophy, and obesity decreases sensitivity of the voltage criteria. These are the voltage criteria for the diagnosis of LVH via ECG, and the Sokolow criteria is the one that is frequently used.